Good afternoon. I'm Professor Zbigniew Solek. I'm a neurologist at the Mayo Clinic, Florida in Jacksonville. My talk today is on biomarkers in spinal cerebellar ataxia type 3. I would like to thank the organizers of this symposium for inviting me to participate in this gathering. Particularly, I would like to thank Professor Jan Sendelin from Plzeň for this invitation. I visited your city back in 1980, long time ago. I still have good memories of your city. I'm sure it looks much prettier right now. It was a very beautiful city. These days is probably spectacular. So before we dissect the subject of my presentation, the organizers of the Congress, as well as Mayo Clinic, wishes me to present this disclosure slide. My funding it's a private funding, and I do not have any special conflict of interest in relation to this project. Like I mentioned, project is privately funded. So what are the spinocerebellar ataxias? It is a group of neurodegenerative disorders that affect spinal cord and cerebellum. In the United States are about 150,000 affected individuals. There are about 50 different genetic subtypes of SCA. Among them, SCA3 is the most common. There is definitely a founder effect for SCA3. These original families originated from Azorian Islands, which location you have on the map on the right side of the screen. Disease has a wide range of onset from 30 to 50 years. There are some individuals with earlier age of onset and later age of onset. Disease usually lasts about 12 years on average, but can last much longer. It is due to CAG repeat expansion on ataxin 3 gene, which is located on chromosome 14. Normal repeat length is 12 to 40. Pathogenic is above 53. So the gene encodes ataxin 3 protein. That will be a subject of my presentation today. That is responsible for cellular protein quality control. So is SCA3 in Czech Republic and neighboring countries? So in preparation of this talk, I contacted Professor Musova from Prague, and she just told me that they have right now 3 SCA3 families. One of them is of Czech origin, one is Algerian origin, and another one in Arabic origin, and country is unknown. And as a matter of fact, their experience in studying SCA3 was published by Dr. Bauer back in 2005. At that time, there were no SCA3 cases in Czech Republic. Now, in Poland, I communicated with Professor Zarembra from Warsaw, and they also have 3 SCA3 families. 2 of them are of Polish origin and 1 of German origin. I also communicated with Professor Sanocki from Lviv, and they do not have any SCA3 families. So clinical phenotype of SCA3 encompasses cerebellar symptoms, gait and balance problems, visual disturbances, Parkinsonian features, spasticity, peripheral neuropathy, and REM sleep behavior disorder. This is a very broad phenotype that is shared with many other types of spinal cerebellar ataxias. And here you have our
my finger, then touch your nose.
Upper extremities, but the situation is quite different when we ask him to walk. Very severely disturbed gait. Now he has a classic MRI picture with atrophy of cerebellum and spinal cord, and he comes from the large family of many other family members affected by the same condition. Treatment options for spinal cerebellar ataxia cases are limited. There is supportive care, physical, speech, occupational therapies. But recently, there is a trial, phase 3 trial of troriluzole compound similar to riluzole. Recruitment was just completed. This trial is specifically for genetic forms of ataxia and also includes cases with SCA3. On the firmament, they are more sophisticated trials, perhaps with antisense oligonucleotides. So we created our ataxia program at the Mayo Clinic in Florida in 2017, so almost 4 years into this program. And our aim was to build a resource of biospecimens for ataxia studies. Our program is actually present on clinicaltrials.gov, and we examine the patients, collect medical records, collect specimens, and we enroll our patients in DIDIT autopsy program. And as you can see, less than 4 years, we were able to collect large group of patients and specimens. Actually, I would like to point to you that we have 95 CSF specimens that we collected from these patients. So in our cohort, the length of ataxin 3 CAG expansion is associated with age of ataxia onset, reverse association, so more repeats earlier age of onset, like in other cohorts that are available for SCA3 cases. So we developed an immunoassay that is very good in detecting poly-Q ataxin 3 protein in human biological fluids. And we published our research recently in October of last year in Science Translational Medicine. And as you can see here, you have a CSF samples, and in SCA3 cases, this level is very high compared to healthy controls, other ataxia, or C9 or RF72 carriers that we have a large collection of the specimens too. In asymptomatic SCA mutation carriers, poly-Q ataxin level in CSF is also elevated to lower extent than in affected cases. The same is in plasma. In plasma, we were able to validate our observation. Dr. Paula Giunti allowed us to use her cohort of patients. Her fellow came to our center here in Mayo Clinic, Florida, and together with her specimens, and was able to work on them using our technology. And you can see in validation cohort, we have very similar results. They have only 2 asymptomatic mutation carriers, and again, even in asymptomatic mutation carriers, this level of poly-Q ataxin 3 protein was elevated. The same applies to skin fibroblasts that we collect here you have SCA3 cases, symptomatic and asymptomatic, compared to healthy controls and other ataxia types. Now, can we detect polyQ-ataxin 3 in urine? We have a paper under review right now on smaller subset of patients. We started to collect urine a little bit later, and we have the similar results in urine specimens as well. So we also checked for neurofilament light chain in plasma and CSF. And as you know, neurofilament is not so specific, is elevated in many neurological conditions. But here in SCA3 cases is very high in CSF, 3,500, as opposed to healthy control for 50 pg/ml, as and other ataxia cases 1,000. So it is also elevated in asymptomatic mutation carriers, much more than in healthy controls or in other ataxias. And that applies to CSF. Similar numbers are also in plasma in our main cohort, as well as in validation cohort. So we looked for the specific SNP. The name is on the slide. And we were able to find that this SNP is associated with expanded allele, the mutated allele. So this is very important because that might develop more precise medication trials that target the expanded allele only. So in summary, I would say that our cohort of SCA3 cases was very instrumental in finding polyQ-ataxin 3 proteins in plasma, CSF, urine, skin fibroblasts. This assay is able to distinguish our SCA3 patients from other ataxias, from C9orf72 cases and healthy controls. And we also find the SNP that is associated with mutated allele. So what next? Well, we are building a longitudinal cohort right now. COVID-19 pandemic slowed us a little bit, but fortunately did not stop us. Over the last year, we're able to bring 20 patients back to our center and recollect these specimens, including CSF. And of course, we are expanding our cross-sectional cohort as well. And another interest of ours is SCA7. This is another type of spinal cerebellar ataxia. Many of these cases have childhood onset, and they also have macular degeneration that leads to loss of vision. So is SCA7 available present in Czech Republic? Answer is yes. Also, Dr. Bauer back in 2004 was able to identify the first SCA7 case. Later, this case was also published in Czech and Slovak Neurological Journal. It is a sporadic case with the 51 SCA7 CAG repeats. So I would like to thank all patients and their family members who participate in our research. I would like to thank many collaborators from UK, particularly Dr. Junti, from Lund University in Sweden, Dr. Pushman, from Trondheim University, Dr. Osli, from Coimbra University, Oregon, and other medical centers in the United States and abroad. As I said, our research trials are listed on clinicaltrials.gov, and you have my email if you wish to communicate with me and be a part of our research. I would like to thank my collaborators, Dr. Petruccelli, who runs the Basic Science Laboratory here, his fellow, Dr. Prudencio, my fellow, Dr. Hanna Al-Shaikh, and I run the clinical aspect of this trial. So thank you very much for your attention.